everyone. Yeah, as Tony said, I'm Robyn, and I am an anaesthetist here at the Ralph. So as Tony said, tonight I'm going to be presenting to you the art of anaesthesia, a tailored approach to the individual patient. Now, I am going to be quite honest here. I could talk for hours and hours on end about anaesthesia, and I quite happily would, but I will try my best to stick to the time. But there is a small chance that I will run out, and I will apologise profusely. So what I'm aiming to cover tonight is I'm hoping to tell you how you're going to approach a case, or how I think about everything and how I go through my process of making up an anaesthetic plan. And I'm going to explain what I consider to be case considerations, and then I am going to go through some case examples. I have 4 case examples, which again, I'm hoping to get through all of them. However, there's a small chance we only get through 1 or 2 of them. Okay, so my husband, who is also a vet, absolutely loves to joke that my job is 90% dexmedetomedy, and I will admit on some days he is probably quite right. I think the important part of my job is to know what to do in that 10% where dexmedetomedy isn't an option. Every patient that we anaesthetize is unique, and as such, their anaesthetic plan should be tailored to their individual needs. This means thinking about what their needs are, what drugs fits that requirement, and when we should be doing things for the patient with the best outcome. As of any profession, we are quite bad at trying to protocolize everything. One part to make our lives a little bit more efficient, and to try and make things a little bit easier for ourselves. So we like to have standardized pre-medication protocols, and for some procedures, some will have a standardized approach to managing hypertension, even sedation plans. And while for the majority of patients this seems to work, it can make things more difficult for us when we do have a patient that doesn't quite fit into the boxes that we're used to. And when we aren't used to necessarily managing an individual patient or thinking about them in that way, it can be quite daunting and it can be quite overwhelming when we all of a sudden have to do that. However, if we try to switch our mindset and get used to thinking about each of these patients and their comorbidities, each time we go on to anaesthetize them, when we find it comes to one of those more complex cases and one of those more scary things that people seem to worry about, we will then be much happier with anaesthetizing those cases, because rather than panicking because they don't fit the box, we're like, yes, I can do this. I know how to approach this, and I'm going to think about this, and I'm going to hopefully get through this without worrying too much. So each time we do make an anaesthetic plan, ideally we should use the same approach, and it means we're less likely to miss something. So the things I will always start with is looking at my patient's history, and this because we want to know not just what my current problem is, but obviously any relevant history that could be leading up to this. So while you might be saying something for trauma, they could have an underlying endocrine disease, for example. And this part of this will also mean that I'm checking their blood results, any tests, other tests that we've done in the past. And for me, that obviously means I'm potentially looking through a couple of different histories from different practices. For you guys, you're probably going to know most of that at the time, because they're generally speaking, they're your patients. They're ones that you're potentially quite familiar with already. So you'll already have quite a lot of this information here. So that's a good place to start. I'm then going to form my clinical exam. The reason I tend to do my clinical exam after I've read my patient's history is because I will always do a generalized clinical exam, but then it means if there's anything in that history that I am concerned about, I'm then going to do a more specific clinical exam based on that. And then going from there, I'm going to come up with my list of considerations, which is what the bulk of this lecture, webinar, sorry, I should say, is going to be about, and how we do that. And then from there, I'm actually going to come up with my plan. Now, I appreciate that this does seem like it will take a horrendous amount of time, and that it wouldn't be feasible in a busy first opinion practice where you are trying to balance operations in between your consults and in between your inpatients. But what I'm hopefully going to show you is actually, once you get into the swing of it and into the swing of thinking about these things, it becomes second nature, and it actually becomes really swift process that actually makes your life quite simple in the long run, because you end up planning for things that are a potential risk of that procedure or their condition. So you've actually got everything ready. There's not this sudden panic later on where you've maybe not got quite the right size of ET tubes, or you've not got the suction ready, because you've already preempted all of this, because you've thought about it all already, and then we're in a really good position later on in the day. So I'm hoping to show you by the end of this that actually it is a nice process, and that actually it can make things that seem quite scary much less scary. So what are my considerations? So when I do anything with anyone, I always say, right, tell me about your patient, what your history, what we've done in exam, and then go, right, what are your considerations for this anaesthetic? And generally speaking, I divide them into 4 sections. So the first one is my general anaesthetic considerations, then my patient-specific considerations, condition-specific, and procedure-specific. And what I'm going to do is I'm going to go through each of them in turn right now into what those mean generally speaking. And then I'll show you how I would apply that to cases later. Okay, so my general anaesthetic considerations. So regardless of the patient, condition, or procedure, hyperventilation, hypotension, and hypothermia can all occur during a general anaesthetic. Now, these are things that no matter what, you could see. And this is because our anaesthetic drugs, the process of anaesthesia, can result in these. Now, yes, some patients are going to be at much higher risk of these specific factors than others due to what's going on in them themselves. But no matter what patient, even if they're fit and healthy, these 3 things can happen to them. Now, I'm not going to spend a huge amount of time going through each of these today, because I could spend an entire hour talking about each of these on their own. But it's just good to know that these are always things that should be in the back of your mind, that no matter what anaesthetic you do, these are the 3 things that could happen. And we will go into a little bit about some of them if they become a specific consideration to that either patient condition or the procedure that we're doing. So my patient-specific considerations. So generally speaking, these are going to be related to things like the species, the breed, the age, the sex, and the temperament of the patient. Now, as you can see, I've added some extra little bubbles here just to show you. From those, then I'm going to be thinking of there's certain categories that we're going to think of. And this is by no means an exhaustive list. It was just to sort of demonstrate. So different species have different considerations. A cat is not a small dog. A horse is also not a dog. So we do have to think about those deviations due to their just being a different species. Then even within a species, there are going to be breed differences. We all know about our brachycephalic patients. They have a huge set of considerations that we have to think about purely because they are brachycephalic. Sight hounds also have some certain considerations that we have to think about as well. Age, juveniles and neonates are very different from adults who are very different from geriatrics. Sex doesn't always play a huge factor, but it's definitely something to also have in the back of your mind, that there potentially could be some sex-related things going on, but again, less likely, but still have to keep back in mind. And one of the big things that makes a huge difference to what we have to do is the patient's temperament. It's wonderful when a patient comes in and they're super happy to be with us and they are easy to handle, they're easy to manage, that's great. But that's not the case for all of our patients. We have a huge number of patients who are incredibly anxious about coming in, and they can manifest this in many different ways. And we want to ensure that we tailor what we are doing to their specific needs at that time. And if that means that we try and get some anxiolysis at home before they even come to us, or if we can have a more hands-off approach with them while they're in the hospital, it's a hugely important factor that we always have to take into consideration. Okay, so condition-specific considerations. Again, this is just to demonstrate this is by no means an exhaustive list. It was just I started adding bits and bobs on here. So there are a huge number of conditions that a patient can have that may not be relevant to what they're actually, or may not be the reason they're in for their procedure with you that day, but they are there and they have to be taken into consideration with everything we do. So we're thinking things like trauma, neuromuscular disease, respiratory disease, intracranial disease, GI disease, even orthopedic disease. While that they might have underlying arthritis, might not seem like a huge consideration, it really can be built into your anaesthetic when we're thinking about things like patient positioning, analgesia for them, and just how to make their stay more comfortable, because having arthritis is not the nicest thing. It's not a benign condition by any means. And then we should try and factor that into what we are doing with them that day. And then obviously we've got our heart disease, which we are all very aware of, and we know how much that can impact our anaesthesia, but also metabolic disease and even cancers as well. Okay, so next we have our procedure-specific considerations. So these are the things that are purely related to what you're actually going to do to that patient. So most of the time, pain and nociception is going to be a huge consideration that we have to think about, as is hemorrhage. But then we also have to think about things of how are we positioning that patient? What is that going to do to the patient? How is that going to impact my anaesthetic? How am I going to access that patient? If I have got someone operating on a head where I don't have access to things like the palpebral and jaw tone, obviously there are two markers of depth of anaesthesia that we commonly use, then we're worried about, well, and how am I going to make sure that that patient stays asleep, or make sure that I'm happy that that patient is still anaesthetized. Obviously, there are other ways, but it's something we should take into consideration. We're then also thinking, okay, I might have great access to the head, or I'll need great access to the head, but so does the surgeon. Is my ET tube in their way for them to do their procedure? So they're all things that start to come together, and we're thinking, right, what can we actually do to make this procedure as easy as we can for everyone involved? And then evaluate, obviously, they're just saying things like pneumothorax. Obviously, if you're doing a thoracotomy or sternotomy, for example, or you can, obviously, you're going to put air into the chest. So we have to consider then how we get rid of that after the surgery. So these are all the things that we're kind of thinking of. And we then sort of create these beautiful layers that we have all these things that are there, and then we layer them together. And you can start to see that there's a common theme in that patient of things that are going to become higher risk or that are more likely to happen. And then we can start addressing those considerations, and we can start thinking, right, what can I do to try and reduce these risks and potentially improve the situation for this patient? So I think the best way to show you how this works and how I would generally think about cases, and sort of give you a little bit about what I would then do in those certain situations, is to actually use some case examples. So first opinion referral, we do see these things from quite regularly. So I've gone for brachycephalic, exploratory tracheotomy, coelotomy, Caesarean section. I'll start with quite the first two. I'm going to go in more depth, and then I'll sort of be a little bit less time on the latter two, just because hopefully you'll see it's quite a similar process I'm going through, and then how I would then go on to manage these. So the brachycephalic. Okay, so the case I sort of came up with, your 4-year-old male entire French bulldog, he is very anxious when he presents to you. You're wanting to do an early assessment with some BOAS surgery plus a castration. Clinically, he's got exercise intolerance, he's got a Sertler Streiser. The carers have also said that he is regurgitating, but he's not on any medication for that just now. So how am I going to approach this, and what am I going to do? So let me see. So basically, what I'm going to think about is those 3 bubbles of my patient, my condition, and my procedure. So if I always start with my patient factors, just because they're the one, that's who you're dealing with. You're dealing with the patient. So he's a dog. Species-wise, he's a dog. So for me, they're kind of in the nicest way possible, my bog standard. They're where every other species deviates from. They are the ones that are just there. They're the nice ones that they are who they are. He is an adult again, so he's pretty much, again, the core sort of everything else differs from here. He's my sort of baseline from what I'm thinking of. So breed-wise, he's a brachycephalic. So when we start thinking about brachycephalics, there are quite a long list of considerations that we think about. But all of them pretty much center around their airway and the potential for GI disease. So airway obstruction is going to be one of the biggest things that we have to take into consideration here. And that airway obstruction can occur at any point. So it can occur through handling, it can occur on pre-medication, on induction, and on recovery. So it's not just that it could happen only one time, it can happen at any point during our anaesthetic where we don't have an endotracheal tube in place. We then have to think about that not only is he likely to have airway obstruction, but his airway is also going to be probably difficult to intubate. These guys have long soft palates, they have everted saccules, we may have some laryngeal claps, we may also have a hypoplastic trachea. And these things together make actually being able to intubate very, very difficult. We've also then got to think about that lovely extra large tongue that likes to get in our way, so it can even just make the actual visualization of the larynx quite challenging. So I'm already thinking here at this point in time, okay, these are things that I can do things about, or I can be prepared for when I actually come to anesthetizing them. So before I'm even giving them any drugs, before I'm even doing anything with them, I'm thinking, right, I'm going to be having my airway equipment ready. I'm going to be having a range of ET tubes. I'm going to be having potentially a rigid urinary catheter to act as a stylet. I'm going to be making sure my laryngoscope is working and that my light is nice and bright so that I can get a really good visualization when I'm trying to intubate. So I'm already coming up in my head these things that I'm going to need, and I'm going to get them ready for what I want to do. These guys also tend to have very sad, quite bulging eyes, so they are quite high risk for eye ulcers developing under anaesthesia. So I'm going to be making sure that I want to have lots of lubrication present. And depending on the type you have, obviously making sure that they're lubricated quite frequently through the procedure. Brachycephalics, as we know, they are quite high risk for regurgitation. And obviously, even if he didn't have a history of it, I would be quite highly suspicious that he could still have silent reflux that the carers are potentially unaware of. So although we know this dog, which we're going to minute, has a history, we're also thinking even if he didn't, it's still on my list of things I'm going to worry about. So this little dog, we've also got a really anxious little friend here. So anxiety is not a great thing for anaesthesia, and it's not a great thing for our patient either. And especially brachycephalic, where actually the anxiety and stress can obviously make them panting. It can get them quite worked up, which again is going to increase our risk of airway obstruction. So I'm going to be thinking, right, I've got an anxious patient. I'm going to want to IM pre-medicate him. That's already thinking there, because I don't want to stress them out trying to place an IV catheter, because at that point in time, I'm potentially going to increase my risk of airway obstruction. It's also going to potentially activate my stress response. Stress response is going to cause an increase in sympathetic drive, and that's going to make us release catecholamines, which is going to increase things like our heart rate, which, yes, in some instances might not seem like a bad thing, but actually can lead to things like arrhythmias and obviously increases just the unpleasantness that that patient is going to experience. And we don't want that to be the case. We want to try and keep them in a positive environment as much as we can. And his anxiety is also going to make it that his recovery itself could be quite challenging. So recovery period for these patients is obviously high risk for the airway obstruction. And then if you add in the fact that he's going to potentially become distressed at that point as well, we're going to even further increase that risk of airway obstruction, but also the risk of him doing harm to himself or a member of staff that is working with him. And we don't want that for anybody that's involved. So from there, we then got his condition. So as I said, this patient has brachycephalic obstructive airway syndrome. So things again I'm thinking about are going to be airway obstruction, which we already mentioned, difficult intubation, hypoxia. The reason being, sometimes these patients, because they are living with already quite a degree of airway obstruction, we might find that they have a slightly increased carbon dioxide level already, and that they might already have a slightly reduced level of oxygenation. And then we're going to go on and exacerbate that, because sadly, under anaesthesia, as we've already said, it causes in all patients, we can get hyperventilation, which is going to exacerbate these factors. We then have a patient who is already regurgitating. So regurgitation, I'm worried about the risk of aspiration and then developing aspiration pneumonia. Esophagitis, which can then obviously go into potential development of stricture formation. And again, I'm going to be worried about airway obstruction. The reason being here is obviously if we aspirate material, obviously that can obstruct your airway. But even just that, the fluid and mucousy fluid that they produce can itself actually just help the airways, the larynx stick together more. And again, that's then going to increase the risk of us actually obstructing our airway. So for the procedure, we're going to be worried about things like pain and nociception. It is a surgical procedure. We are going to be making incision. That is going to, we're going to have nociception. And pain and nociception are both going to increase the stress response, which again is not something that we want to have. It's also an unpleasant experience for the patient, and is going to increase things like our anxiety about coming back, because obviously if we are experiencing pain while we are in and we are associating it with an area, we're all going to try and avoid that, and dogs are no different in that respect. So then we've also got our patient positioning. So he's going to be in two different positions. So we're going to have sternal for his airway surgery, and then we'll be in dorsal recumbency for our castration. And when we turn him into dorsal recumbency, we are going to potentially see more hyperventilation because we're lying on our back. Potentially increased of VQ mismatching, so ventilation perfusion mismatching, because we have turned him on his back. His lung fields, most of them are located dorsally. We turn him on his back, we increase development of atelectasis, which is then going to obviously again increase the factors like hypercapnia and hypoxia, all of which we've already got risk of. And then we've already, as I said, finally got blood and airway swelling, which again is going to increase our risk for airway obstruction. And finally, the actual access to the patient. So when we are doing BOAS surgery, their head is away from whoever is actually monitoring the anaesthetic, which can make us feel a little bit less at ease, because a lot of us do rely on palpebral and jaw tone for keeping an eye on our depth of an eye position, sorry, I should say, for depth of anaesthesia. And when we then can't assess these as frequently as we would like, it can make us feel a little bit less at ease. We're then also going to be worried ET tube is potentially going to be in the way, or there's a risk of it becoming kinked as the surgeon is manipulating it while they are doing their surgery. So this is something that we're going to have to think about. So now that I've got all of these thoughts and I've listed them, and I kind of in my head as I'm going through this, and I've seen this patient, I will start listing these down in my head. And then what I'm going to do is think, well, how do I mitigate these risks? What am I going to do about this? Because it's great knowing all about these things and what I'm worried about, but then what am I actually going to do about this to make it better? Okay, so the first thing I'm going to think about is, how do I manage this anxiety? Because that is something I can actually do something about even before he comes into the hospital. So if I can, and I know this patient's coming, and I can have this discussion with carers about what we can do to make their lives a little bit more pleasant when they come to see us for the day of their procedure, I am going to try and get some medication into them. So I typically will use, for dogs that have anxiety and that aren't on any other medication, I'm going to typically use trazodone with or without gabapentin. There are some studies out there, and you can look at them, that will potentially use things like melatonin as well, or instead of trazodone, we'll use ACP tablets. But I do use a lot of trazodone for these kind of dogs, and I think it does work quite well. So typically I'm going to use about 10 mg per kg of trazodone, and if I'm going to add in gabapentin, I am going to add about 10 to 20 mg per kg. And I'm going to do that the night before surgery and the morning of surgery at least. And that can actually just create a nice sort of relaxed patient, or at least a little bit less anxious about coming into the practice, which can actually really help with being able to manage that patient while they're in with you. For some of them that have even potentially been that they can't have IVs placed, even with this on board, actually then they become amenable to IV placement, which is actually fantastic, and can make your life, one, it's really nice for the patient. They are so much more comfortable. They're not worried about being in here. They're not getting themselves worked up. And it makes obviously your life feel a little bit easier, because you're not worried about, I am pre-medicating a dog that might obstruct their airways. So if I can do that, that's going to be great. If not, if we can't do that for whatever reason, they've come in and they've ended up that this is just how they are, we weren't expecting this for whatever reason, then I'm going to use an IM pre-medication. So in this patient, obviously IM pre-medication, there's a period where we have drugs that are taking effect that are potentially going to cause airway relaxation, and therefore increase the risk of airway obstruction. And we're not going to have an IV, we're not going to have a secure airway. That if they regurgitate, then we can necessarily manage that as effectively as we would like. So what we ideally want to do is we want to have them be sedated quite quickly so that we can then get that IV in, and then we can get that airway secured, and make sure that we are in a happy place with that patient. So I am going to use drugs that are going to give me quite a profound sedation potentially, if they are in the point where prime sedation, and I can get that IV access quite quickly. So I will typically use an opioid and an alpha-2 agonist in these patients. As this is a painful procedure, I'm going to use either a full mu or partial mu agonist. In him, because I'm going IM, I'm probably going to go for methadone because the volume is going to be lower. And I think it's nicer to give a lower volume of injection because it's less uncomfortable for the patient and they're going to tolerate it slightly better. But if it's buprenorphine you've got in your practice and that's what we have, then I would definitely, you can lean towards that as well. So I said, yep, sorry. Pain and nociception is the next bit I'm going to be thinking about. So opioids, said full or partial mu agonists. But I'm also going to be thinking about what local anaesthetic techniques I can use. So opioids have their place, and I do use them in most of my patients. But we also then want to not just rely on them to be our sole form of analgesia, because we like a multimodal approach, and we want to be trying to target nociception from multiple different pathways. And we also want to try and potentially reduce the use of opioids in this patient specifically because of the respiratory depression that's associated with them, but also because the gastrointestinal signs that we can sometimes see with them, which obviously in this kind of patient, we maybe want to avoid from that point of view. So local anaesthetic techniques, they're great. So for his surgery, so assuming we're going to be doing nares, soft palates, then I would be thinking, okay, I can do an infraorbital block. So that will hopefully block his nares, make them nice and comfortable. And for the soft palate, I would admit I actually use topical lidocaine on soft palates. So Intubes, I would be using that. Or actually just spraying on a lidocaine from the vial. There are other blocks you can do, and they're a little bit fancier, but I think in most situations where this is actually quite easy to do, and I found it to be, seems to be give some form of analgesia, and it means it's quite simple for you to do in wherever you are, basically. For his castration, we can do intratesticular blocks as well, which again is going to add to our overall analgesia, because we don't want to forget about his castration. It's not the most comfortable procedure, and his face is also going to be comfortable, so we want to try and address everything that we're doing. So we can use either lidocaine or bupivacaine for these local blocks. Lidocaine has a slightly faster onset but a shorter duration of action compared to bupivacaine. The main thing you want to do is make sure that we are calculating the maximum amount he's allowed and dividing that between the areas that we are going to be using in. Because the risk that we've got here is, we're like, we can have a mil here, mil here, mil here, but then we actually forget that there is a dose that we don't want to exceed, which for bupivacaine I'd be working at 2 mg per kg, for lidocaine it'd be 4 mg per kg, and I wouldn't be wanting to be going above that. You will find that that volume is quite excessive and you wouldn't be getting to that, but always have that calculated because we don't want to reach a toxic dose. I'm going to think about paracetamol in this friend, IV, and then we can send him home on it orally as well. I will use IV 10 to 15 mg per kg, and I will give that every 8 or 12 hours depending on the patient. And then we have the question of whether or not we will give this patient non-steroidals. So non-steroidals are great in the sense of they reduce inflammation, which sounds quite nice in this patient, because actually reducing that inflammation may help with airway. We may then be thinking, actually, that's going to improve or reduce the risk, sorry, I should say, of airway obstruction. However, the caveat to that is by giving a non-steroidal, we really can't be giving a steroid. So if they do have an airway obstruction and we did want to give them steroids, we're kind of stopping us being able to do that. So I typically don't give them non-steroidals. The reason being, the ones I'm normally seeing, there is a good chance they're going to get steroids as part of their procedure. So I will have those discussions typically with the surgeon, and we'll make that sort of decision there. What we will find is, obviously, if they don't have it, then yes, potentially in the post-operative period, if we're happy with them, then yes, and there's no other GI signs associated with the anaesthetic, which these guys can get. I would say yes, we can send them home on non-steroidals if we're happy with them. So that tends to be what I do. It's not to say that's the right thing to do. It's not the only thing you can do, and other people will do it different ways. That's just the way that I personally work. Okay, so then we've got our airway obstruction and swelling. So this is the biggest factor that we need to worry about, because this can be quite serious for our patient if it does happen. So the biggest thing you're going to do is you're going to make sure you're ready before you even start. So you're going to have everything you need. So we're going to make sure that we have all of our airway equipment, so ET tubes. We're going to have varying sizes, so much smaller than you think you're going to need, and quite long, because they really do make a big difference. I like a rigid urinary catheter, so I can use this as a stylet, but I can also use it to provide oxygen if I am really struggling. And I said, a really nice bright laryngoscope that's got a long enough blade that can reach to the base of the soft base of the epiglottis, so that you can really make sure that you are doing everything you can to see what you're wanting to do and give you the best chance of being able to intubate that patient. I am going to try and keep them as calm as possible throughout the entire procedure, because I don't really want them getting wound up. I don't want them panting, because these are going to be really increasing in the way of airway obstruction. And when I get to that recovery period, I am going to have reintubation stuff ready to go, even if I think there's minimal chance of airway obstruction happening, because actually they have a pretty nice airway, because it's better safe than sorry. This means I'm going to always have whatever ET tube I used in the procedure, I'm going to have a couple of sizes smaller than that, because there is going to be a degree of airway swelling there. So I want to have that ready to go. Induction drugs, so whatever you've used, so propofol or alfaxalone, I'm going to have them all there ready to go in the recovery period. We can also think about nebulization in the recovery period. So patients we will nebulize with either potentially adrenaline or hypertonic saline, which can really help with the swelling in their airways, and can again help try and reduce that airway obstruction. If they had trazodone, hopefully that will help in your recovery period. If they've not, then I will potentially lead towards maybe giving them some ACP, or depending on the patient, somewhere between 5 and 10 micrograms per kilo. Or if they have, I'm still going to have some dexmedetomidine, or medetomidine, sorry, waiting and ready to go. So I use obviously quite a lot of dexmedetomidine. I will typically have 1 microgram per kilo ready to go, just in case we do have a bit of a panic, and then have that at hand to give them on recovery if need be. And yeah, that's typically what I would do. The biggest thing for these is being prepared for the airway obstruction, and having everything ready to go when you're needing it. So then his regurgitation. So we know that this patient has been regurgitating. We're going to anesthetize them, which again, and then we're going to be moving them. So he is at risk of regurgitating. And obviously, highest risk periods are going to be when we don't have secure airways. So, because that's when we're going to potentially aspirate. So we want to do everything we can to try and reduce this from happening. So patient positioning is going to be quite important. So I'm going to make sure that I keep his, after he's had any medication, I'm going to try and keep his head up. Gravity is your friend. Head up, stomach down, keep the fluid down the way. And I'm going to try and do that until I've got a secure area. Once I've got my ET tube in and I'm inflated, yes, they can still regurgitate, but at least I'm hopefully reducing the chance of them being able to aspirate that material. Medication wise, there's a lot out there that you can look at, and that will that doesn't really give us confidence in what we can actually do drug wise to stop this from happening. And it seems that we can try a lot of different things, and few of them actually really stop them regurgitating under the anaesthetic. But everything we're going to try and do is just reduce that and mitigate some of the risks associated with it. So I will give these guys omeprazole, 1 mg per kg, typically obviously BID, if I can, before the procedure for the night before the morning of, but at least 90 minutes before the procedure, I can give it IV. This isn't going to stop us regurgitating, but what it is going to do is make the fluid that we do regurgitate less acidic, which is going to be less damaging to our esophagus and our airways if we do then aspirate, which obviously improves their situation. Meropitin I will give these guys as well. Again, it's not going to stop us regurgitating, but it will stop us vomiting. And it's also going to just make us feel a little bit more comfortable, a little bit nicer in ourselves. It'll hopefully reduce a little bit of nausea. I don't think there's a negative necessarily to giving it, hence why I do include it in for most of these patients. I know it's not going to stop them regurgitating, but at least there's it's going to hopefully, I said, stop vomiting and just make them feel more comfortable in themselves. So then we have metoclopramide. So there was one really nice study. They used a very high dose of metoclopramide combined with cisapride, and they did actually manage to reduce the risk of regurgitation in the brachycephalic patients. However, they used an incredibly high dose of metoclopramide to do this. And the higher the dose of metoclopramide we give, the more likely we are to develop neurological signs. And if we happen to have a patient on trazodone, we're really increasing the risk of them developing a serotonin syndrome, which obviously we don't want to have. So for these guys, unless I am incredibly concerned about the regurgitation, and I'm in a place where I know I can appropriately monitor that patient, especially in the recovery period, for neurological signs and for serotonin syndrome, I'm not going to be using the high doses that were reported in that study. I'm going to typically be using somewhere between 1 to 2 mg per kg today. And this is just because you're then weighing up as the benefit, does the benefit outweigh the risks associated with having that high dose of metoclopramide? So I said, patient, I'm going to try and position head up until they're cuffed and intubated. And the biggest thing I'm going to try and do is not reposition this patient too many times. So we know that repositioning and moving from table to table really does increase our risk of regurgitation. So we want to try and position. We know we are going to have to move this patient because he's having a procedure that's going to be in 2 different recumbencies, but we want to try and keep those as minimal as possible and only do the ones we really need to do. And then I'm going to be prepared for when he does regurgitate. So I'm going to have suction available and ready to go. I'm going to have it with me wherever I am with him. And I'm going to make sure that I have stuff that, I can suction everything out. And I'm going to make sure I know what I want to do. So if he is regurgitating and I have a secure airway, that's fine. I'm going to recheck that ET tube cup. I'm going to make sure it is nicely inflated. I'm going to suction it out. I am then going to try and flush that esophagus as best as I can. That can be quite challenging. It sounds really easy, but some days it can just be very difficult, and that's okay. But I'm going to do the best job I can. If he's not intubated, so if it's on induction, for example, obviously if you keep their head up and they are regurgitating and it's coming out, there is the risk that it will then, sadly because of gravity, it is more likely to then go into the airways. So at that point, I'm going to actually tip their head and I'm going to make sure I'm trying to drain it away from the larynx. So kind of hanging them over the edge of the table to get as much of that out as possible and then secure their airway as rapidly as I can. I have sadly seen when patients have had meals potentially, or they have regurgitated and they've aspirated the chunky material, because at that point in their anaesthetic, and it is not pleasant what can happen from it. So we want to just try and make sure that it stays clear of that larynx as much as possible. Once we've got an ET tube in, we're then going to try and clean out as much as we can, again, flush out the esophagus. Because on recovery, then we're thinking, okay, I don't really want to, if we've regurgitated at this point, I'm not exactly wanting to re-anesthetize that patient to then suction out that esophagus. So if they're regurgitated and they're sitting up and they're seeming okay in themselves, I'm going to just try and clear as much as I can without obviously stressing them out, but I'm not going to be re-anesthetising them to try and flush out the esophagus. Hopefully they'll then go and have something to drink at some point later in the day to try and get rid of what is in there. And finally, we've then got hyperventilation. So this was one of their other considerations that we have to think that we do have to think about. It is specific in this patient, so it's not just an anaesthetic consideration, it is actually quite specific in this patient because of the breed, because of the positioning, and the drugs that we're going to give. All of these things can contribute to the development of hyperventilation. And as I've already said, they're already potentially a little bit hypercapnic, a little bit of a reduced oxygenation level, even before we get to them. So what we want to do is we're going to know that they're probably going to hyperventilate. We're going to try and make sure that their depth of anaesthesia at all times is appropriate. So we're going to try and avoid excessively deep anaesthetics, which we should be doing anyway, but then know that it is likely that we're going to have to mechanically ventilate these guys. And if you've got a ventilator, great, you can use that. If not, it is sadly going to mean for someone IPPV manually. I, generally speaking, will tolerate up to a end-tidal carbon dioxide of about 60. Then it's above that, then I will start to intervene. But that's what we need to be aware of and how we want to manage. That's generally speaking, that's how I'm going to manage my brachycephalics for this. A lot of these considerations are quite similar to even if they had other surgical procedures. But that is generally what I would do with them. So let's go on to the next one, the emergency XLAB. So here is our beautiful Labrador. She's a 5-month-old female and tired Labrador. She has a 5-day history of vomiting. She's not passed feces in 3 days. She's quite dull. She was at a family barbecue 7 days ago. Up to this point, she was previously quite healthy. You've taken an X-ray and you suspect an intestinal foreign body. And on that X-ray, there is quite a lot of dilation of the small intestines, and the stomach does look quite full. And you suspect, sadly, that she's eaten a corn in the cob, because it looks like on the X-ray. Okay. So what am I thinking? So first of all, this patient, she's young. She's not neonate, but she is still quite young. She's not fully grown. So my drug metabolism may be affected. And this will be through just the fact that our maybe our sort of metabolic pathways aren't as mature as they should be. Our volume of distribution can be a little bit different. So I'm just gonna be aware that some of the drugs might be potentially slightly longer acting than they were, or might have quite the same effect as they were. That I would be expecting. She may also have a slightly immature cardiovascular system, so our little baroreceptors might not respond to the changes in vascular tone quite as well as a mature adult would do, so potentially we're going to be higher risk for hypotension. Again, our sympathetic nervous system might not be as fully developed, and again, just because of that, so lack of sympathetic tone, again, we might be a little bit more an increased risk of hypertension. Now, at 5 months old, I'm not going to be hugely concerned about that in Labrador, but it's always just going to be in the back of my mind that age might play a role in these things. And then we've got our condition. So the condition in this patient is obviously potentially quite serious. We've got an intestinal foreign body. And this is going to lead to intestinal dilation. We've got the gastric dilation that we've seen on the X-ray. And this can have quite a negative effect on our patient. Obviously, it's uncomfortable, but then we've also got potential it's going to cause pressure on our diaphragm, which is going to potentially lead to hyperventilation. We're potentially going to have some inflammation of those intestines. And given the length of time it's in there, we're going to be worried about could the intestines even have perforated, even just small, but we could be thinking about these things. And if we do have perforation, we could have a peritonitis, so septic or non-septic. And then that's potentially going to lead to inflammation and irritation of the other abdominal organs. So our pancreas is in that area and is potentially going to become quite angry. And this can also then go on to lead on to systemic inflammation, which can then lead to vasodilation, which is then going to be increasing our risk of hypertension. We might also see our third spacing of fluids, which can be into the abdominal cavity itself, into the intestines, so into the lumen or into the wall, or just generally sort of peripherally. And again, all of this is then going to potentially contribute to worsening hypovolemia and therefore hypertension. We have obviously been vomiting, and we can also have some regurgitation, because if we've got a distended stomach, we are at risk of regurgitating. So we're going to be thinking hypovolemia, dehydration, electrolyte imbalances, and these are all going to contribute to the development of hypertension. reduced tissue perfusion, and that can go on to obviously affect organ function and then potentially even impact things like wound healing. We've then also got the pain associated with the intestinal foreign body. So you're going to have dilation within the abdomen itself, and that can be quite uncomfortable. It's also going to cause a stress response, sympathetic nervous system activation, which is again going to negatively impact our anaesthetic risk. So we've already started adding quite a lot of things to this patient, which we maybe wouldn't have thought about in the past because we're like, oh, it's intestinal foreign body, it just needs to come out. But there's quite a lot of things we're thinking of for this patient. The vomiting and regurgitation, we've already said about the hypovolemia and dehydration, but then we've also got the risk of aspiration associated with that. And we've also got nausea that's going to potentially be causing. And while it might not seem like the biggest issue, in the postoperative period, that is going to lead to potentially inappetence. And we know that how important nutrition is actually for our intestines to heal. If we don't have good nutrition to our intestines, then they're not going to heal, which is potentially going to increase the risk of wound breakdown. So the procedure itself, well, it's a surgical procedure. Pain and nociception are all going to be consideration. And as I've said, it's going to potentially lead to stress response, and it can again increase the risk of inappetence, which is not going to be ideal in this patient. Positioning wise, we're going to be in dorsal recumbency, and that combined with potentially quite distended abdomen is going to massively increase the risk of hyperventilation. So then we're going to potentially get hypercapnia developing, and potentially if we have atelectasis then developing, we could end up seeing a decrease in our SpO2. Again, it's unlikely, but it's there in the back of my mind. When you're in position in dorsal recumbency, we are also going to have compression potentially have compression of the vena cava from the abdominal organs. Now, in a healthy patient, it's not normally cause much of an issue, but in a patient that is hypovolemic, then this is going to reduce our venous return and therefore potentially worsen our hypertension that we see. So we've got quite a few considerations for this patient, but they all come back to really hypertension, aspiration, pain and nociception. So they are generally what we're going to be coming back to in this patient and how we're going to then manage those problems. Okay, so the first thing I'm going to do when I'm thinking about this patient is really, I want to make sure that they are as stable as possible before they can go to actually be anaesthetized. So we know that this patient needs fluids. We've got vomiting, we've had lots of vomiting, we've got fluid in her stomach. She's probably feeling really sorry for herself. This is how much fluid is going to be based on your clinical exam, what our heart rate's doing, how our blood pressure is looking. But I know that I'm going to look at those and then I am going to address that. So the type of fluid I'm going to use is I'm going to depend on any concurrent electrolyte abnormalities. So for example, if they are hypovolemic, I am going to use saline with added potassium as my sort of fluid that's going to be there to replace the deficit, to be there as my background in fluid therapy. For actual bolusing, obviously if I've added potassium to a fluid, I'm not going to be using that for my bolus, so I'm probably going to lead to either probably just a Hartmann's or just a normal saline, non-spiked, to actually manage that, to treat their fluid deficits. And I'm going to monitor and continually monitor. So I'm going to obviously be reassessing the situation as I'm going through this. So I'm going to be looking at her saying, right, what's my heart rate? What's my blood pressure? How much am I assessing this patient to be potentially dehydrated? How behind on my fluids am I? We can do things like we can look at, we can pop a scan, ultrasound on the heart, and we can try and look at how full is our ventricles, sorry. But generally speaking, I'm going to be going, right, what's my heart rate and what's my blood pressure doing? I'm going to give an amount of fluid, which is going to depend on that exam. But if I'm thinking about boluses, I'm going to be thinking somewhere between 5 and 10 mil per kilo, depending on those findings. And then I'm going to reassess. I know that she might then look really good after that, things might improve, but things can change quite a considerable amount after we've given that, even during the anaesthetic. So I'm not just going to say, yeah, I've done that, that's fine. I'm going to be reassessing. So for this patient, I am going to be keeping a very close eye on their heart rate and their blood pressure. And I'm not just going to say, oh, I've already done that. I'm going to be continue thinking I may need to do that again. So she is going to be at risk of hypertension, and one due to the lack of fluid that's there, but also due to the fact that there is systemic inflammation there, and vasodilation occurring probably in her body. So we want to make sure we have a plan for this and how we're going to manage this. And in this kind of patient, I'm going to lean towards probably noradrenaline, CRI, and that is because vasodilation is going to be contributing to what is going on in this patient, and that she is likely to have been already in quite a high sympathetic drive, and may have actually started depleting her own noradrenaline stores. So I want to try and give her that back. So I'm going to be thinking about adding that into the thinking about managing her blood pressure in that way, along with obviously my fluids. I'm also thinking when I'm going with anaesthetic drugs, I want to try and avoid a profound effect on the cardiovascular system. So I'm going to want to avoid things like alpha-2 agonists, and I'm going to want to try and avoid vasodilation. So things like ACP. Sadly, our inhalants and our induction agents, they all typically do cause vasodilation and a bit of negative inotropy as well. So I want to try and reduce the amount of them I have to give. So I want to be using anaesthetic sparing drugs along with these. So things like fentanyl CRIs, ketamine CRIs, and local regional anaesthetic techniques to try and minimize the amount of other drugs that cause vasodilation I then have to give. So once I'm actually happy with my patient, and I think, right, we're at a place where I'm okay, I think we've got a better situation cardiovascularly, and then I'm going to go on and anesthetize this patient. So as I said, analgesia is always important. Analgesia should always be considered in every patient. I think pain has a lot of systemic effects we probably don't think about, and we really should be managing it as best as we can. So I am going to use in this patient probably a full mu opioid, so methadone or fentanyl. We can give some paracetamol to this patient, and I am going to be using some local regional anaesthetic techniques as well if I can. So I'm very lucky. I can do ultrasound blocks like tap blocks, and I can do epidurals if I wanted to with morphine, but we can also do things like line blocks, so incisional blocks, and they might not be necessarily as effective as some other local regional techniques, but they're definitely going to add something. And I think that is a really important thing that we can do for this patient. I'm also going to be thinking about is there anything systemically I'm going to begin intraoperatively? So things like, as I said, fentanyl CRIs or ketamine CRIs, they're going to not just be analgesic, but they are also going to be anaesthetic sparing. So these are things I will definitely consider using in this patient. Then we've got to think about our vomiting regurgitation, and it's very much the same as when we're going to be with our brachycephalics. So we're going to have everything ready because we're going to preempt it happening. But in this patient, we could also consider things like, actually, if our stomach is that distended, can we place an NG tube beforehand and actually empty the stomach a bit to try and reduce that from happening? It'll also make her feel a bit more comfortable as well, which obviously that'll be quite pleasant for her. And once we are intubated, we might even consider, do we just actually pass the stomach tube and empty your stomach at that point as well? So as I said, I thought I'd just add this in for this one because I know it's quite a lot of questions I get asked about what I would do with these patients. So I am definitely be thinking my pre-medication would be methadone or fentanyl. My induction would then be either propofol or afaxolone, whichever we have. I'd probably do a co-induction with midazolam or fentanyl. Again, it just depends on what drugs you have available to yourself. And then maintenance, Tiva, I quite like in these guys. That's just because that's what I personally prefer. But inhalants, great. I still use inhalants actually probably most of the time, but if I get the chance, I'd like to use a Tiva. And then I'm going to be thinking about things like fentanyl and ketamine CRIs and all the local regional techniques that we talked about. And then once I'm happy, I am going to give them antiemetics as well, because I want this patient to be comfortable and not have nausea in the post-operative period, which is going to obviously be not very pleasant for her. Okay, so the Caesarean section. This one I get asked lots of questions about, and I will admit they were my favourite thing as a resident, because it was always good fun, just because it was something a bit quite nice to have in with me. So this one I haven't actually given a case. I'm just going to generally talk more about what we're thinking about, because we have an extra person that we have to think about when we're talking about a Caesarean section. So we're no longer just thinking about one single animal, whether that's a cat or a dog, or obviously potentially equine as well. We are now thinking about a fetus, or puppies or kittens that are foals if we're into equine, who are going to be coming into the world, and we need to be aware of what effects we're going to have on them. So the patient specific, because I haven't given a patient, I'm not going to go through anything for this one, but they're going to be specific to the breed, the species that we have there. So condition. So pregnancy has a huge number of effects on the body. It's not just we have a big uterus, there's fetus growing in there, great, there's a wonderful array of effects, and I could talk for a very long time about the effects of pregnancy. But generally speaking, they're going to be things like pregnancy is going to potentially cause hyperventilation. We're going to have a reduced FRC, functional residual capacity, which is the really important part of our lung volume that allows us to remain oxygenated even when we have pauses between breathing. We're going to have potentially reduced thoracic compliance. We have a smaller tidal volume. Our respiratory rate, though, will increase to try and compensate for that. But basically, all of this leads to an increased risk of hyperventilation and hypoxia, which when we anesthetize these patients. Pregnancy also increases your blood volume, but also alters your volume distribution. And this is then going to affect how our drugs are distributed and how our drugs are metabolized. Our gravid uterus means our abdominal organs have less room. And when we're thinking about it, we're specifically thinking about our stomach. So we have a much increased risk of regurgitation in these patients as well. We also have to consider our placenta. So our placenta is incredibly metabolically active. It has a huge blood supply, and it is what is getting everything we need to our puppies, to our kittens. And it's therefore making sure that it has a continued undisturbed blood supply to that placenta, then go on to the puppies and kittens, is hugely important. So we don't want to interrupt that. We also have to think about the cardiovascular system itself. We have alterations in the cardiovascular system. So generally speaking, their heart rates are going to be much higher. We're going to have a higher sympathetic tone. And just generally speaking, their bodies are a little bit more under sort of a higher pressure. They're much more metabolically active. So when we give our drugs, they're potentially not going to act in the way that that we would normally expect them to act. And obviously, then we have to consider that anything we give to mum is going to go into baby, which we'll go into in a minute. If we are doing C-section, we're going to presume that this animal has some form of dystocia, whether that is a failure to progress or that we actually have a very much stuck fetus coming out. But generally speaking, these animals are not in the nicest position. They're not in a good place at that point in time. They're potentially going to be quite distressed. They are potentially going to be in a very vulnerable position. So they might have changes to their temperament that we need to think about. They're potentially going to be laboring for quite a while. So they're going to be fatigued. They are going to be quite a stressed high sympathetic drive. We could also have hypocalcemia being present. And generally speaking, they're going to be, as I said, they're in a very vulnerable place at this point in time. And that is obviously something we definitely have to think about. Procedure, when we are doing a C-section, patient positioning is a huge problem for these guys. So as soon as you turn any pregnant patient onto their back, the risk of hyperventilation really does increase quite dramatically. And they can really struggle. We also have the risk of developing hypertension because we then have a big gravid uterus pressing on our internal, our main vessels, mainly our vena cava, which again is going to potentially reduce our venous return. This is something we have to think about. We also have pain and nociception, and again, we've said that before, pain and nociception leads to an increase in stress response. But in this patient, if you then got a sore wound, and that is near our mammary glands and our nipples, we are then going to potentially not want to feed our young. So we have to think about that. And then we've got our little fetuses, our little babies. So anything we give mum can potentially cross or not anything, but a lot of the drugs we give mum are going to cross the blood placenta and into the fetus. And therefore, whatever effects those drugs can have in mum can also happen in puppies and kittens. So the big things that we're going to worry about are respiratory depression, cardiovascular depression, and sedation in these little ones. And that's because they're all going to potentially risk morbidity in those young, but is also going to potentially reduce the chance of them wanting to go on and feed. They're going to potentially reduce heat-seeking behaviours. So again, that's going to potentially prolong, make them at higher risk of potentially then, as I said, not feeding, getting cold, becoming hypoglycemic, which we all have to worry about at that point in time. Not only that, do we have to worry about going into them, depending on how long we've been labouring for and depending on what has been going on, then we need to think about these little animals are potentially going to be quite distressed themselves. So again, that's going to contribute to potentially development some morbidity in these animals, sadly. So what am I going to do? So my main focus is always going to be mum, because without her, there is a higher risk of mortality in the young. That's not to say I'm going to forget about the fetus, the babies. I'm just going to have to think about mum first and then them second, because as I said, without her, they're going to have a much harder life. And there's a lot we can do for them while still thinking. So there's a lot we can do for mum while still taking into consideration what we can do for the puppies and kittens. But to try and find trying to balance, what I'm always going to be thinking is, what can I give that is going to be short-acting and is reversible? Because if it's short-acting and reversible, then the effects on the puppies and kittens will hopefully be minimal, or we can at least try and get rid of those effects. So things like opioids, so short-acting opioids, some short-acting, but we also have naloxone to treat that. Alpha-2 agonists can also then have atropamazole. Now, it might not be appropriate in every case to be giving alpha-2 agonists. But for example, if you've got a very fractious mum who is really in a place where she's not allowing handling because she is terrified, then actually it might be the best thing to be able to give her is that actually giving her an alpha-2 agonist is potentially going to be beneficial, because it's going to allow us to do things with her without stressing her any further. And then we can antagonize it in the puppies or kittens if we are worried about them in the postpartum period. So ideally, the first thing we always want to do before we even start thinking about getting to anaesthetizing them is trying to get an IV in, and obviously checking blood, so PC fetal solids and our electrolytes if we can, and if we have any problems, then addressing them. If we can't do that, if mum is like absolutely not, which I can completely understand, then we are going to have to do some form of IM pre-medication. And as I said, not stressing your patient and pushing them to their limits, which can potentially cause harm to you and to them, is definitely what we want to be doing. IM pre-medication and reducing the stress associated with that situation, reducing the stress associated with trying to place an IV, reducing her worry is very beneficial. We are going to have a much happier mum in the end, which is beneficial for everyone involved. So I think rather than trying to restrain them and trying to get an IV in, we want to be kind. We want to just say, do you know what? Let's try just IM, let you do your thing, and then we'll go from there. So if we're going to have to IM, I'm going to be using an alpha-2 agonist. I am probably going to give some methadone in this patient, because she is potentially going to be quite sore. I can antagonize it, and I want to have it on. I want to have some form of improvement in my sedation with there. Not everyone is going to do that, and some people will avoid it at all costs, but I personally feel analgesia is great, and in all honesty, as I said, I can antagonize it in the puppies if I need to, and it's going to make my life and her life much more pleasurable to be able to actually get safe delivery of the puppies or kittens. Can also use alfaxolone IM in some patients as well. It's quite a large volume you have to give though, so there's some patients that will not work for. But in cats, IM alfaxolone, I think the volume's acceptable and it does work quite well. As I said, if I'm going to have to, I am going to make sure I have everything ready to be able to antagonize those drugs in the neonates when they're born. So naloxone and antipamazole, so I'm going to have them ready. If I do have an IV in place, because mum is happy, she'd let me do that, it's not caused too much distress in her, then I am going to be thinking, okay, what can I give her? So I'm thinking short-acting opioid. So I'm very fortunate. I know I have fentanyl and I can use that. And I know by the time they are born, the effects will be minimal, or I'm going to have naloxone there. However, if you are worried, and you know that there are other analgesic techniques that we can do that are going to be make sure that mum is still comfortable during the procedure, then I know there are a lot of people out there that won't give any opioids in their pre-medication. Because they do cross the placenta, there is the chance they're going to cause respiratory depression and a little bit of sedation in the puppies. But as I said, we do have naloxone, we can use it. If I do have the ability to use other systemic analgesia non-systemic analgesia, then we can obviously go towards them. So local regional techniques over systemic analgesia. Induction, I'm going to be thinking, what can I do? Or what is going to be my biggest risk in my induction periods? So that is going to be regurgitation. Usually it's going to be the biggest risk. A lot of the time, these guys won't have eaten for quite a while, but they can still regurgitate. So again, it's like we did with the brachyes, like we did with their foreign body. We're going to be thinking, head up, make sure we have suction ready, intubate, cuff the tube before you put the head down. Induction agent wise, I am happy to use either propofol or alfaxolone. Alfaxolone is shown in studies that it maybe does have better puppy vigor scores in the immediate post-stop period. However, the outcome was the same between propofol and alfaxolone and was the same. But I guess, given that there is some evidence there, more people will lean towards alfaxolone. But if you don't have alfaxolone in your practice, that's fine. Propofol is going to be okay. Big thing for these guys is going to be the positioning. So positioning is really important. Ideally, we want to use a little bit of a head-up positioning to try and keep gravid uterus just off the diaphragm and just try to help them ventilate a little bit better. And ideally, if we can, potentially you do want to try and tilt them to the left, or at least while you're doing things like clipping and prepping, just because this will try and keep the pressure off the vena cava a little bit, and again, potentially help improve venous return, and therefore less of an impact on your blood pressure. Because basically, as soon as you turn the gun back, you've then got a big gravid uterus that is lying on your vena cava, reduces venous return, and your blood pressure can get quite sad with that. Intraoperative analgesia wise, so I know that I can, there are techniques that we can use in these patients. So I typically will use epidurals in these guys. However, I know that's not also an option for everybody everywhere. So again, we can be using things like tap blocks, we can be using line blocks, which are definitely appropriate in these situations. And I think local is great because hopefully it'll make the actual wound itself quite comfortable, and then she's going to be more likely to want to feed her new babies. Otherwise, I will give paracetamol to dogs, obviously, not to cats. And this is, I think, definitely something we can give. There's obviously a lot of discussion over whether or not we should be giving non-steroidals, as they do go into milk and then potentially will go to young. And a lot of people will typically give them one dose of a non-steroidal. But I do quite like paracetamol for dogs and for these patients. So hypertension is a big risk for these guys. And as I said, it happens when we position them, but then it also happens when we try and take the uterus, when we lift the uterus out. And that's basically because if we think of your uterus is kind of acting like a splint. So it's giving us smaller space for the blood to go through. And then as soon as you take it off, everything sort of just relaxes. So you've got the same volume in there, but more space to fill. So your patient becomes more hypertensive. So when you think about fluids, make sure we're treating with fluids, make sure that we are, make sure we're treating with the fluid therapy. And then, as I said, if we can position them, try to tilt them off onto the left side, just to reduce that help venous return. And then obviously we want to think about those babies. We're going to have potentially quite a few So we need to make sure we've got enough people to manage them. We want to have a nice warm environment for them, so making sure that we do have an incubator, lots of warm towels, everything there, because mum's obviously not going to be able to do her job because she's going to be anaesthetised. Suction for their airway, make sure we've got oxygen with little tiny oxygen masks available, and making sure we do have naloxone and we do have atipamezole available for them is really important. And then making sure that we do have our ET tubes potentially for bigger breeds. Obviously for smaller breeds and cats, it might just be a little catheter that we use potentially for the airway just to help give some oxygen. But these are all things that we can do. And if we do need to give drugs, obviously we can. They're young, we can give them intraosseous. So they are obviously there, and that's the benefit that we've got for them. Tony is now going to go through some questions, and I will hopefully answer them.
Yes, thank you so much for Robyn for a really informative and interesting presentation. Okay, so we've got quite a few questions. We'll try and get through them as quickly as possible. Robyn, if we could give maybe an email address for anybody who would like to ask any additional questions or any help with any sort of anaesthesia cases, that would be great. Okay, let's start. So first question, what sort of breed considerations should we give specifically to sighthounds? Are they more prone to hypothermia due to lower body fat?
Yeah, so sighthounds, hypothermia is one of the big considerations. I also think about when we're thinking more, I guess, greyhounds and things, and one of the big things is they, sorry, I've got to get the right way around because I always get the wrong round. They like to break down their clots a bit better. So I typically do use tranexamic acid in them, just because I know that they break down clots quite effectively, and therefore actually can get quite a lot of bruising, and we might find that they tend to bleed a little bit more. So in those kind of patients, I do tend to give them tranexamic acid. But otherwise, yeah, generally for the sighthounds, it's the fact that their skin is really friable. So just things like clipping, you can nick the skin quite easily. It's things like, yeah, they're very skinny often. They need to have, we need to be aware that they're going to potentially get quite cold. They also are quite bony often as well. So again, positioning, we can get quite a lot of pressure points on certain muscles, which can be quite uncomfortable for them. So it's just those general things that I'd be thinking about in the back of my mind. And yeah, sighthounds as well. There seems to be a lot of anecdotal evidence that they may be more likely to have become an increase in potassium under the anaesthetic. It's not often that it necessarily happens, but it seems to be that they're more common for whatever reason that may be, that they might develop hyperkalemia. And anaesthetics is always just in the back of my mind, that one. But that's generally what I say for sighthounds.
Great, thanks, Robyn. Okay, next question. Hi, we had a cat spay who had a quad, including methadone. During the procedure, its tongue started moving slightly. Other parameters were normal, so heart rate, eyes. They obviously had a multi-parameter machine on. Any idea what we could have done given to, any idea what we could have done or given?
I guess that is something that I would have to say, and I would probably sit down and have a proper chat with you about. So if it's one that, if whoever's question that was, wants to actually have a chat about that, it'd be something to email about, because there's a lot of things I want to ask you in return about what were you doing at the time and things. So I'd love to say I could give you an actual answer now, but definitely if I will give my email at the end, and then you can email me and we can have a bit more of a chat about that.
Brilliant. Okay. Do you ever use metoclopramide to prevent regurgitation?
So the evidence to say that it actually prevents regurgitation is pretty, it's really variable. The studies that we had that actually said in brachycephalics to actually stop them regurgitating was really, really high. I think it's like 1 mg per kg per hour rather than 1 mg per kg per day. So I will use it. I tend not to use it at that higher dose, unless it's in a very specific patient that is already regurgitating, because I know that it still might not stop it, but the hope is that it will improve things. Yeah.
Okay. Do you ever do a mix of lidocaine, bupivacaine for your local blocks? So do you have a recommended recipe?
I personally don't. I tend to use a lot of mine. I just use bupivacaine because I know by the time I've given them, there is enough time for them to be effective by the time we actually start surgery. So for me, I've always just used bupivacaine, potentially with something else in it. So it will be potentially usually a morphine or potentially an alpha-2 with them. So I don't typically use, and off the top of my head, I wouldn't necessarily have a recipe for you, sadly, but it is something that people do, and I can obviously give more advice on, but I'd have to actually think about it a bit more.
Okay. How much adrenaline do you use for nebulization? And can you also repeat the medications you use for nebulization and at what doses?
So adrenaline, again, this is something that I do usually have to double check, but I usually use, this we've got to decimals, right? 0.1 mg per kg, and then I dilute it into a couple of mils of saline, got the word there, and then just nebulize that. With hypertonic saline, that is something that is I become more recently started doing, and it's usually a couple of mils we put in ours. Our nebulizer, sounds odd, I think holds about a maximum of 10 mils in it. So that's the maximum we're going to use for that. So yeah, and that's hypertonic saline we've done with that one.
Okay. Do you pre-oxygenate before you induce your brachycephalics? And at the recovery point, do you also oxygenate? And do you tend to, at what point do you tend to extubate? The absolute latest or much earlier because of reducing trauma?
So it will also always depend on the patient. So if they will allow pre-oxygenation, then yes, I will pre-oxygenate them. But this is making sure if I am going to do it, I'm going to do it, we want to do it properly. So that is going to be a tight fitting face mask for 3 to 5 minutes. If they're not going to tolerate that, then I'm not going to do it, because the stress of doing it doesn't necessarily outweigh the benefits, because stress in these guys is obviously not what we want to do. If I've been able to pre-medicate and I'm not too concerned by their airway, and while we're going through our checklists, then yes, I will pre-medicate them, not pre-medicate, sorry, I will potentially pre-oxygenate them while we're doing that if they become a bit calmer. But I'm not going to be like, you must be pre-oxygenated. I'm going to sit here until it's happened. That is not going to be beneficial for the patient. I'm going to be saying, right, you're not tolerating this. No, we're not going to do. And it's the same with extubation as well. So I will happily leave them intubated as long as they're tolerating the ET tube. So, and as long as that is not going to be detrimental to the patient themselves. So patients that are brachycephalics that are calm already, that are pretty chill, I'm not worried that they're not going to become distressed with it, then yes, I will leave them intubated, and I'll extubate them at the last possible second. Like when they're like setting up, they're trying to lick it out themselves, you can see they're ready to take it out. Otherwise, I'm going to basically be like, well, if you're a patient that I'm worried is going to wake up and your go-to is going to be sadly trying to bite, then I'm not going to try and keep that in forever, because that's not fair on you. Because to have that stress, to then have you potentially cause yourself or someone harm, that's not fair on that patient. So then I will extubate them slightly earlier, but it's all going to depend on that patient and that individual situation.
Okay, what are the current thoughts on how long to fast patients before an anaesthetic?
Oh, so this is a huge discussion. Again, I could give a huge, very long lecture on. Typically right now, I'll give you my short answer. I was saying at least 6 hours, 4 to 6 hours for most of my patients. However, if anyone wants to have that, whoever that was, wants to have that full discussion, I'm more than happy to at some point, but that will take a while.
Great. Okay. Another nebulization question. How long do you nebulize for, and how often?
So usually do it not about every 10 minutes, please don't say that one, for about 10 minutes, or until the nebulizer says it's got no more. And I think we normally do it that's where I've got to, I just shove it on and it comes up automatically. I think I think it's every 4 to 6 hours. Again, I'd have to just double check that one. And I think, but yeah, that's usually what we would do. And yeah, it's usually about 10, 15 minutes. If they get bored of it and they run off before then, again, I'm not going to force them to do it if they're not the kind of patient that's going to sit and actually tolerate it, I'm going to be like, we're just going to leave it.
Okay, question on ondansetron. Any thoughts, advice on the potential applications for ondansetron?
So, ondansetron, it's only really recently that I've started using it, and because it's not licensed, and it is still quite expensive, which obviously we shouldn't necessarily always we shouldn't be worrying about cost, but obviously, because if it's the best drug for the patient, it's obviously something I want to be able to offer them, but at the same time, I'm always going to be mindful that it is more expensive for those patients. I think it is, in my personal opinion, I feel it is better for nausea. So if you have a patient that is very nauseous, I think it seems to be better for them compared to meropenem. So I would tend to use it in those situations, or where I've had given meropenem and I'm just not quite happy with what the effect that I've seen with it. So they're still just looking a bit, in my opinion, because obviously it's hard to know, is the patient nauseous or is it pain that they're potentially experiencing. So in those ones where I am a little bit concerned that it might be contributing, and we've had meropenem, then that's when I'm going to go next to that one.
Okay, regarding the recovery of the brachycephalic patient, if they get stressed, do you use metadormidine to control the anxiety? If so, what would the dose be and how often can it be administered?
So alpha-2 agonist, yes, I use quite frequently for brachycephalics in the recovery period. Typically, if I'm worried, I'll give it even. So I've usually, if they've not had trazodone, for the recovery, I'll always give them ACP to start with. So 5 to 10 micrograms per kilo, and then I am then going to give and I'll try and give towards the end of the procedure, or something into that. And then I'm going to have dexmedetomidine or medetomidine on standby. I use dexmedetomidine, so I would use 1 to 1 microgram per kilo, which is going to be roughly 2 of medetomidine, sorry. And I'd have that on standby, and I'll either give it just before, like as I'm turning off my inhalant, and I'll give it then, or I'll wait and see how they start recovering, and if I'm worried, then I'll give it at that point. If I'm giving that, and then as I see the effect of the alpha-2 starts to wear off and their stress levels start to increase again, then I will typically start these guys on a CRI of an alpha-2 agonist. And from dexmedetomidine, I would be using somewhere between 0.5 to 2 micrograms per kilo per hour. So for medetomidine, I'm going to be sitting somewhere probably between 1 to 5 micrograms per kilo per hour. And that's what I will typically do for them. Rather than just repeatedly bolusing them, I just tend to put them on a CRI of it because I find it to be quite effective.
Okay, so we have a human anaesthetist online.
Okay.
And they've said they're very interested to learn from the veterinary world. We're specifically going to be talking about metadormidine. So what the person said, we're still finding our way with this medication in humans, but you guys have been using it for years. Are there any patients where you will never use dexmedetomidine, and any patients where only dexmedetomidine will do, maybe in terms of physiology rather than species?
Oh, I will admit, alpha-2 agonists, they're one of, they have such a wonderful place in anaesthesia as long as you're using them appropriately. Cardiovascular disease, depending on the type of cardiovascular disease, is where I will be cautious with my use. There are some patients where alpha-2 agonists are appropriate, or are okay to use. So thinking more towards those that are not in heart failure. So any patient with heart failure, I'd be avoiding them. However, patients like cats with hypertrophic obstructive cardiomyopathy, with anterior motion of the valve, I will happily using them at low doses, because there are some studies that show that it can actually get rid of the anterior motion of the valve. Some stenosis, so pulmonic and aortic stenosis, again, low doses of them if again the patient's not got huge changes to their ventricles, again, I will potentially consider using them in those patients. Certain intracranial diseases, so if they've got potentially raised intracranial pressure, quite profound, I will maybe be again more cautious in using them, but in some other neurological conditions, I will definitely consider them. It's a great conversation, and it is something that I love to talk about, because I am, as I've said, my husband said, so that's basically my job. I just like alpha-2 agonists, and I will happily say I do. That is something I love to talk about. And again, if anyone wanted to actually discuss, if you wanted to discuss that further and a bit more into what we use them for, I could speak for hours on it, and definitely would definitely love to have that conversation. Because I'm fascinated about human anaesthesia, because I think what you guys do is great.
Okay. Would you consider using NSAIDs for painful mums post-operatively, or is this too risky, considering it is also contraindicated?
Yeah, so it's a hard one, and I'm not going to say there's a right or wrong answer. I think there are a lot of people that will give a single dose, and I think, mum's going to be really uncomfortable. I definitely think it is worthwhile. I know in the human world, and I can say from experience, I was given post C-section, I was given paracetamol, and I was given ibuprofen. There is the risk of effect on the neonates there. So giving them a one-off dose while post anaesthetic is probably the benefit of it. That is where I definitely do probably more towards paracetamol for dogs. It then does make it more difficult for cats, and you're like, this is why I think then using local techniques really can help improve their well-being, because it is a hard situation, and it can definitely be a conversation you have with the carers. It can be an informed decision that you have together. We know that the evidence is we can read all the leaflets. They say do not use in this, do not use in lactating dogs or cats. But if we have those conversations, we say, hey, look, this is the potentials here of what could happen, but at the same time, this might benefit mum, and she's looking pretty, we think that she really needs this. I think that's an open discussion to be having with them.
Okay, next one. Do you worry about alpha-2 dropping the heart rate of your fetus if you pre-med mum with it?
Yes, I absolutely do. It is definitely something that can happen, and it is something that we do worry about. And then that is, again, it's never an easy conversation to have, because obviously there's a potential that's going to increase the mortality in those the fetus and the neonate. But if it's needed, because mum is potentially not in a good place, because mum is really unhappy, we can't handle her, we are talking about trying to get these puppies out safely, but we also need to think about mum and how safe she is, and actually what's best for her. We can antagonize the alpha-2 agonists in the puppies or the kittens. We can do that when they're born. And I think it's having that balance of, right now, what do I need? And if it's, I need mum to be in a better place, because right now she is so stressed, I can't do what I need to do with her. I'm going to be thinking that's the best thing for her at that point in time. And then I'm going to manage what I can do with those puppies and kittens that when they're out, and we can deal with them then. Because yes, it's something we worry about. We're not going to say it's not something we worry. We can't say we're not going to worry about it, because there's a chance there. But it's, if I need it, I need it.
Okay. Would a lidocaine CRA be safe to use intraoperatively as analgesia and MAC reduction in a C-section?
I personally don't like, I'm not a huge fan, and I will admit this, of lidocaine CRIs. I think the side effects we get, the analgesia we get from them versus the side effects we get from them, I don't necessarily think they're actually worthwhile. Not worthwhile, that sounds awful. I think that the things that we're going to get with it, I can get appropriate analgesia for something from other reasons, and I'd rather reserve my lidocaine or my bupivacaine for local blocks in that situation, because you can do a line block, which I think would be much, which would be preferable in that situation. I think with them lidocaine, you can get things like, obviously, they can become quite nauseous with them, which is not what you want from someone, because then she's going to start feeling pretty rubbish, and that's not going to be great in the recovery period. So it's not something I typically would use.
Okay. What is the recommended dose for ketamine CRI?
So I typically use somewhere between 5 to 10 micrograms per kilo per minute for a CRI intraoperatively, with a bolus usually to start with of, depending on the patient, about half a mg per kg to 1 mg per kg or per kg, depending on if I've given it in their pre-med or not. So that's typically what I would use. Post-operatively, if I was to continue, I'd usually drop it down somewhere 5, 3, somewhere in that range is what I'm thinking.
Okay, dose of atipam, please, for puppies and kittens if you do need to antagonize.
Oh, it's been so long since I have had to do it. I always just double check the formulary for that one, and I will happily admit that because I do it so infrequently. And it's not a number I keep on top of my head. So I do just normally look it up for that. And which, if anyone wants to email me, I have the about that, I have the resources. It's just not a number I keep on top of my head, sadly. I think the last time I did a C-section was, oh, probably about 4 or 5 years ago now. So long gone, that number, sadly.
Okay, someone has asked, they've never flushed an esophagus before.
Mm.
How do you specifically do this? They've also asked that they missed why you don't use alpha-2 in an XLAP.
So alpha-2 and XLAP, I'll start with that one because that's an easy one. So it depends on if they're sick or not. The case I presented was a systemically unwell patient, and in a systemically unwell patient, I typically won't use alpha-2 agonists, just because they have quite profound cardiovascular effects. These animals are typically, if we are hypovolemic, are going to be relying on a heart rate to potentially maintain their blood pressure. And then we're potentially giving a drug that is going to drop their heart rate, but might not have the effect on the vessels that we were expecting. So we might not see quite what we want to see. We still might have quite profound vasodilation, and therefore actually it has quite profound cardiovascular effects. So I tend not to. If they're fit and healthy, as in you've noticed a foreign body, but they're systemically well, then alpha-2 agonists in those situations I would be happy to use them. Flushing an esophagus, it's quite a messy situation. I normally pass the stomach tube into the esophagus, so don't go down into the stomach. I just pass it into the esophagus, and then I will flush with using catch-up funnel at the end, and then I'll flush with water or saline. Or you can use the same suction tubing you use for actually suctioning. You can get the similar type where you can then use a syringe and push in, pull out, push in, pull out. It's really cat-handed. There is no, I'd say, easy way of doing it, and everyone has their slightly own variations in what they do. You then can instill sodium bicarbonate into them, and there's recipes online because there's slightly different variations in how much you should give, and if it's obviously you'll want to check if it's acidic. So acidic regard, so you want to try and measure the pH. So we want to try and so you can do that as well, but it is a pretty messy process. But generally speaking, it is just make sure each tube's past some form of tube that is appropriate to that patient. So yeah, either stomach tube or your suction tubing, pop it down, and then yeah, just flushing with either water. And I will admit, I don't use obviously cold. It will be sort of lukewarm, because obviously if you're putting a whole bunch of cold fluid down, your patient's going to be really hypothermic. So you want to make sure you're just trying to get rid of as much of the debris as you can, and kind of just do it until the stuff that's coming back out. So as you're suctioning it back out, so you're sort of flushing in, suctioning out, flushing in, suctioning out, is definitely cleaner.
Okay. Post-op analgesia for our feline patients that have had C-sections. Obviously, NSAIDs are not ideal. You can't give paracetamol. What do you do, Robyn? And what about also introducing gabapentin? Is that an option?
Yeah, it's a hard one. It's a really hard one, and I don't think there's any of us are going to be able to give you an answer that we'll all agree on. So you can think about any drug that we give is potentially going to end up in milk, and then potentially going into puppies and kittens. So I will admit, oral buprenorphine. I will send them home on. That is something I have done in the past. Gabapentin is not something I've necessarily used, I guess, because I find that they can be a little bit more, I guess all of them, there's a risk of they're going to be a bit more state. Mum is going to be a bit more state as well, so maybe her activity around the kittens as well is potentially going to be as good. I think, yeah, I do typically lean to probably giving them a dose of these non-steroidals, which again, if I'd have that conversation with the caterers and obviously being like, this isn't really ideal, and then send them home with oral buprenorphine, which again, it can go from mum to kitten anyway. But that just tends to be where I personally lean towards. And I make sure I am using local for them at that point in time as well when they're in the hospital. So hopefully by using local, we can minimize actually the pain, the development of the pain. So we're trying to sort of stop it happening and stopping it being as bad rather than wait it. Then we've not used local, we've done an incision and then we're trying to get on top of the pain afterwards. It's much better if we've tried to use that local. Hopefully the actual process of the development and the sensation of pain will actually be damped and we will hopefully have a better place to start with. So when they do go home, they're not going to be in a place where actually they're as uncomfortable as they would have been without it.
Do you consider the body fat when you are calculating doses of anaesthetic agent?
I do, but it depends on the patient. Sometimes it is really hard to estimate, and I guess there is a huge amount of, well, how much fat is fat, or how much of the patient, sorry, is fat, and if I work on my lean body weight. So usually if I'm thinking for pre-medication and stuff like that, if the drug has a relatively wide safety margin, I'm going to be thinking, well, I'm probably going to still try and base off my lean body weight, but I'm probably going to be slightly less, I'm not going to be as worried about it. Induction agents wise, I'm going to be giving to effect. So again, it's not like I'm just giving to effect to see what we have. So again, at that point, I'm not really thinking, oh, their lean body weight is 10 kilos rather than 15 kilos. I'm just saying, right, I'm giving it to effect to get the desired effect. And at that point, I sort of kind of forget about it. But then yes, would be working with my lean body weight for like the pre-medication. However, when it then comes into potentially a patient who is not best pleased with us, and I am potentially going to have only one shot at giving this patient an intramuscular injection, I'm then probably going to be like, well, actually, if I'm going to have one shot and that is all I'm going to get, I'm going to be thinking, well, I'm probably going to base it nearer what your actual weight is, unless you are like 9 out of 9 body condition score. Because if I'm only going to have one chance, I'm going to be like, well, actually, I need you to be anesthetized, because I need you to be in a good place where we can manage you safely without you injuring yourself or injuring one of us.
Okay. I've suggested giving methadone IM to C-sections due to more studies showing it doesn't affect the life expectancy. But still find vets are reluctant, and have said if anything goes wrong, they won't be covered by the BDS. Where do we stand on this, Robyn?
I mean, I think this is where we've gotten to a point where we are worried about, obviously all of us are worried about what carers are going to say if something doesn't go right. And we are in a very vulnerable position right now, and we all do worry. I think that it is something that if we have studies that are showing that it's okay, and we have read that, we understand it, then we are going to be supported in what we do. I can't say as I said, I'm happy to use opioids in patients, in patients for C-sections, because I understand what I'm doing and I understand the effects it could have, and I'm mitigating the risks and hopefully the puppies and kittens when they're born by having everything ready to go. And given the fact that we know that we have done it, it's not like humans don't get given opioids. Yes, they get given different opioids, they get shorter acting opioids, but that makes me quite sad that that's what people are thinking. And I know that is what they are thinking. But I would be saying there's a study there that shows it. I would hope, and obviously I can't speak for the VDS, and that they would support it. I don't know, because I've never been in that situation, and I will admit it's not necessarily something I would have even thought about, because when it comes to me and what I'm doing with them, I'm thinking, but this is the best in this situation right now, and I can defend what I am doing in that situation. And I think that is, for me, that's very important. Oh, that's such a hard thing to say. I'd be saying I'd have some confidence in knowing that we have studies that shows that, yes, we know things can happen, but if we've got one that's saying this actually is an okay option here, that I would hope that the VDS would be saying, yeah, great, let's go with, that's okay. But I can't speak from that one. But from my point of view, absolutely, I was saying, I do give them, I give them IM methadone, I have given them IV methadone in the past, because that's what they needed at that point in time. They were in a horrendous situation. And so I have given them that, and that was okay, and that's what I had to do, and I can defend those actions, and I was comfortable making that decision.
What causes the patient reaction to the snapping of the ligaments? Does it depend on the depth of the anaesthesia, or is it about the pre-med combination and the duration that comes into account?
There's a lot of different things. I think nociception is a huge factor in that. Your depth anesthesia, the lighter you are in your plain anesthesia, you're more likely to use R. We don't get rid of, or that sounds awful way of putting it, but when we are under anesthesia, we don't get rid of our sympathetic, responses. They're still there. We want them. We want to be able to still react to certain things happening. Like, we want to have blood pressure responses to changes in various pressure. So when we do have a patient that is got something that can activate our pain receptors, they will still react to it. And I think that is definitely a contribution to that. It can also be that sometimes it is just potentially we've not done anything hugely stimulating for a little while, and then all of a sudden we've done something quite stimulating. It can also be the point where some of your drugs are starting to wear off, and we do find that then potentially they are more likely to react. When that happens, I will admit I am a great fan of alpha-2 agonists in the appropriate patient. They can actually really be quite useful in those situations, and I will give them intraoperatively at that point in time, if I see that they are responding to it. Because I think they've got the analgesic there, they can help stabilize, sort of just settle everything a little bit more, and just make them more comfortable.
Okay, I've got an interesting question here. My surgeon often gives propofol in teeny tiny increments and then intubates the second they deem the patient is asleep enough. I feel, as the RVN, this approach leads to greater likelihood of excitement and paddling, and makes the patient harder to settle, and then you rely more on isoflow. Love your thoughts on this, as I don't feel informed enough to raise my concerns to the vet.
So I think that's one. Again, if you email me afterwards, we can have a bit more of a discussion, because there's just a couple of things I want to ask him, what teeny tiny increments are, how often. I want to have a bit more of a thing, just so I get a better understanding of that, and I think then go into that in a bit more depth, because otherwise we could. The way I'm taking this, there's two very different tracks that we could go on for this. So
another one for neonates. Do you antagonize sublingually or intraosseous?
it depends on the situation. If I'm very, very worried, then I'm going to go more intraosseous. If I'm less concerned, I'm like, oh, we can just say sublingually, it's fine. But it's going to depend on that one and the situation where they are, and how, I guess as well, how comfortable you are with intraosseous as well. I'm relatively comfortable with it. It's something I've had to do in the past, but if you've never had to do it before, it's your first time doing it, then giving them sublingually is going to be absolutely something you can do. And I would definitely be, at least it's easier to attempt, to definitely doing that, rather than necessarily cracking out the intraosseous if you're very worried about doing it.
Okay, why do you not use ACP on recovery if you give, say, trazodone pre-visit?
So, the combination of ACP plus trazodone can increase the risk of serotonin syndrome. Given the doses we typically use, it's probably unlikely. So there are some patients I will probably do it in, but I generally, unless I feel it's really needed, I will be sort of more cautious in that respect.
Thank you very much to everybody. Robyn, if people still have questions and discussions they want to have about particular cases, what would be the best contact details for you?
So my best contact is my work email address, which is spelling is my name is spelled there, robyn.thompson@theralph.vet. Otherwise, we have our advice email address for if you actually ever want case advice, if you have a specific anaesthetic that you are going to be carrying out and you would like advice for an anaesthetic plan. We as a team, we have an advice email address, which is advice.anaesthesia@theralph.vet. And that is something that we have that if you are needing any specific anaesthesia advice, we can give you that. And every one, we have a team of 5 anaesthetists, an intern and a resident just now, but we've got some other members of the team starting, and one of us will hopefully get back to you at some point within to discuss the case that you've potentially emailed us about. If you're wanting just general, I have a case, this is what we're worried about, and what would you do? That is something that we can definitely help you with. But if it's anything to do with this presentation, or you just want to say, hey, I've got this thing, I want to think about this, or you want to chat about something in general, please just use my my own work email if you're happy to do so.
Just wanted to thank everybody again for joining us this evening. I hope you guys found it informative. And like I said, any questions, anything at all that you need, any support, we are absolutely here for you. Please just let us know. So just to say thanks again, and I hope you guys enjoyed the presentation.
Yep. Thanks everyone. I hope you have a nice evening. And yeah, if anyone ever wants to talk anaesthesia, I will talk the hind legs off a donkey. So please do.
Thank you.
Thanks.